Dare to Diagnose players. This is the answer to this September Dare to Diagnose. Firstly, let's think about what this echo looked like. Many of the pictures were suboptimal, so full assessment of the left ventricle really couldn't be done. But everybody was in agreement that there was hypertrophy and that the septum was more hypertrophy than the rest of the left ventricle, so asymmetrical hypertrophy, which is consistent with hypertrophic cardiomyopathy, which is what this patient had. You also agreed that the continuous wave Doppler that was provided to you was abnormal, but there was some question as to whether this was an aortic stenosis, mitral regurg, or left ventricular outflow tract dynamic obstruction jet. Let's review what these jets would look like before we continue with the rest of the evaluation. An aortic stenosis and a dynamic left ventricular outflow tract jet will be seen only during the ejection phase of systole, we see here, whereas mitral regurg and tricuspid jets can be seen throughout systole, pansystolic, even during the isovolemic contraction parts. Now, the difference between an aortic stenosis and a dynamic outflow tract jet is that during aortic stenosis, the obstruction is fixed, and therefore the jet is symmetrical, bullet-shaped. Whereas during left dynamic outflow tract obstruction, the obstruction, as stated, is dynamic and therefore increases as systole proceeds, and the jet velocities will therefore also increase as systole proceeds, leaving an asymmetrical jet or a dagger-shaped curve. Okay, let's look at our study now. This was the PArasternal long axis. We can see an enlarged left atrium. We can see that mitral valve, anterior leaflet and posterior leaflets. We can see this very hypertrophied septum, and we can see thin, pliable aortic valve leaflets that are opening well. If you look very carefully at this mitral valve, you can see that at some points it gets sucked into this outflow tract during systole, which implies that there is some systolic anterior motion, or SAM, present. Would have been good to have a nice color flow over that part, or maybe an emote through that mitral valve leaflet to confirm that. Next up is the short axis view, confirming the very small cavity hypertrophied left ventricle. Our apical picture is quite rotated, and therefore we don't see the right ventricle very well. We're rotating almost into a two-chamber view here. What we can see from this is again that large left atrium with a mitral valve that's opening well. Here is that continuous wave Doppler jet, which hopefully, now that we've reviewed those other jets, you can see that this jet is not symmetrical, increasing towards the end of systole with a more dagger shape, meaning that this is a dynamic outflow tract obstruction jet with a fairly high velocity, therefore significant outflow tract obstruction is present here. Our subcostal view, once again confirming this very hypertrophied septum, with also some degree of RV hypertrophy here. And our IVC with a small diameter and very collapsible. So what is our summary findings? We have a hypertrophied left ventricle with asymmetric hypertrophy, mostly septal, with an outflow tract obstruction that is dynamic and significant, likely some degree of systolic anterior motion of the mitral valve, as well as a very collapsible IVC, implying some degree of hypovolemia. How are we going to manage this patient for anesthesia, for insertion for a gamma nail? Let's plan this anesthetic based on our framework and with our goals in mind of maintaining preload, afterload, minimizing contractility, and controlling rate and keeping the patient in sinus rhythm, which would be our goals for a patient with HOCM. If we look at our pre-anesthesia framework, we could optimize this patient by giving some volume. If the hemoglobin is normal, we would use Ringer's lactate or plasmolite in increments, 5 to 10 moles per kilo, to see how the patient responded. We would ensure that labs were normal and order blood products if appropriate. We would make sure that there was an appropriate risk discussion, confirm resuscitation status with this patient, and then we would consider our options and surgical consideration. So the options for a gamma nail would be a lumbar plexus block, a spinal or epidural or combination thereof, or general anesthesia. You all suggested that a near-axial approach in this patient would be high risk because of the vasodilatation, and I would agree with that, although it's not completely undoable if it's titrated and well managed. How would we prepare? We would set up the OR with our appropriate resuscitation drugs. For this patient, I would suggest that would be a phenylephrine or vasopressin infusion. And additional equipment, we might want to have the crash cart in the room to put pads on this patient's chest in case of arrhythmia, as they are more prone to arrhythmias, and it's also difficult to resuscitate once the rhythm deteriorates because of the dynamic outflow tract obstruction. CPR is not super helpful. Intraoperatively, so our monitors will be the standard CAS monitors, plus I would consider an arterial line, large for IV proximal access for our pressors. The positioning for a gamma nail would be supine in the traction bed, an attraction table, so nothing additional required for that. So we want to make sure the patients stay warm and resuscitated, and you'd want to plan to have something in place to monitor that. So either ongoing transthoracic pictures or potential for TE, if that was available to you. No special considerations for emergence other than we want to control the heart rate. Post-op disposition. For post-op disposition and analgesia, we might consider some kind of nerve block to control pain. And depending on how the patient does in the OR, a potential for monitored bed afterwards. The next problem that was presented to you was low intraoperative blood pressure. My differential diagnosis would likely be hypovolemia and an increase in the LVOT obstruction, either because of a combination of hypovolemia or pain, CO2. It could be an embolic event from the kind of surgery that we're doing. And always when you have a low blood pressure in the OR, you have to think and look for anaphylaxis, otherwise you'll miss it. How will you treat that? We will do volume and vasopressors, control the rate if it became too fast, if there was any kind of arrhythmia going on. My pressors of choice would be phenylephrine or vasopressin. If persistent hypotension, I would consider doing an echo to see what was going on, and definitely look at getting an ABG to assess for those underlying H's and T's. And that is the end of the September Dare to Diagnose answer. Thank you for playing. See you next time. Continue to focus on your focus.